last but by no means least, Peggy Okane.
Thank you. First of all, I want to just say how much I appreciate everybody on this panel. I've worked with all of you in various ways, and I just have the highest regard. And I also want to call out the giants of patient safety and quality, like Brent James, who I think did so much to inspire us. And I think quality is about inspiration. It really is. I don't know the secret to inspiring people, but I think it's the way that we need to think about it. And by the way, they shouldn't lose money if they do the right thing. I guess that would be my only addendum to Dan Ariely's comment about pay for performance. So I just wanted to start with a personal note, because I started my career, I was a French major in college, and I decided I didn't want to be a French teacher. So I became a respiratory therapist, and I did that for 5 years. And I would say patient safety brought me to quality. There were so many things that I saw about how we were organized, and I knew that the people that I worked with were all there because they wanted to help people. We were all there for the same reason. I'm going to tell one story because it goes to Brent James in a way. I remember being called up to a floor as a respiratory therapist, and there was a patient that had multiple fractures, and he had adult respiratory distress syndrome, or shock lung. And I had never seen this before, but I saw this patient, and I said he needs to go to the ICU right away. And an attending from orthopedics came to me and said no, and that patient died the next day, and that was seared in my heart, believe me. And then I remember reading about LDS having done protocols for ARDS that reduced the mortality rate by, 50% or more. And I just wonder, are all hospitals today using that protocol? And is everybody kind of recognizing that? That would be a measure of quality. The good ones are, yeah. That's part of my message today, is the disparity between the good ones and the average. The comments about infections, I too remember being in a meeting where the understanding was there was nothing we could do about it, including somebody from the CDC that was there also felt that way. And I just want to call out Paul O'Neill, who's not here today, who showed people how to go after hospital-acquired infections, I think, in so many wonderful ways. So I also want to say, Don Berwick, another inspiration. I agree with him. Patient safety and quality are twins, and yet I think the idea to make the report about patient safety was brilliant, because it got the attention of people in healthcare and the public, and that was what we needed to do. So for me, quality is, did the system do the right thing? Did everybody in it do the right thing? And did the right thing get done the right way? And I think in that sense, we've come a long way. I had the same data that Rick just called out. I want to call out one more, which was an article that was published last year in the New England Journal about the complications of diabetes. And it found that the complication rates overall were down by about half. And that includes things like blindness, amputations, horrible, horrible sequelae, heart attacks and strokes. And so I think if there's one thing that people are working on in the ambulatory sector, and I love that ecology of medical care because it's so important for us to keep that in mind, it's diabetes, and there have been dramatic improvements, and we still have a long way to go, but it's better. I think turning on the lights, so that we can see. We can't see everything. We still have lots of blind spots. But that is an accomplishment that we all ought to feel really good about. And I think this is our 25th year at NCQA, and we feel good for the role we played in that. I think expectations are higher, and that's a good thing. And I want to call out CMS on its very strategic use of payment and transparency to, I think, get the attention of the healthcare system in a way that I've never seen before. So it's inspiring. Actually, there's a downside to it too, Patrick. Somebody from a plan said to me, I don't have time to work on my commercial quality because I have to put all my energy into the Medicare Advantage. So I guess that's kind of sad but true.
We want them to work on both.
So, and I think we're in the best of times and the worst of times. And so I'm dazzled by but I'm already out of time. I'm dazzled by the best, and I'm impatient about the rest. So let me just say one more thing, one more topic I'm going to go over, and Carolyn's too far away to hit me, so. Cancer, I have just gone through an experience with my family member. I think all of us really resonate, and we all know people that have had it, and we've all seen what they go through. Cancer hospitals, I think, are still exempt from quality reporting.
A voluntary program, but they're exempt from the value-based purchasing.
Let me just say, I don't think that's right, and my relative can tell you about that. He had he had infections, he had uncoordinated care, there were failures to act, and this was in a blue ribbon cancer hospital. So we have a lot of work to do, we have a lot to be proud of. We should use our energy and feelings of pride and satisfaction to mobilize ourselves for the next stages, which are more complicated, but I think there's still a lot of potential. So thank you very much for the opportunity to be here.
Well,